Very good afternoon, everybody. So, I think we'll wait for a couple of minutes and then we can start today's talk.
Okay, sir.
A very good afternoon, everybody. I think we can start now. Is it okay? So, those who have come early, they should not be kept waiting. So, I think with that principle, we will start. I will just share my slides. So, today we will be deliberating upon hypertension, diagnosis, management, and complications. So, we had the World Hypertension Day, the 17th of May, every year is taken as the World Hypertension Day. And the whole month of May is attributed to hypertension awareness, diagnosis, screening, and a host of activities, public awareness activities. So today, as part of this lecture, was because of the Indo-Pak skirmish. Also, we had to shelve this presentation at that time. So this is scheduled for today: hypertension diagnosis, management, and complications. So I will just go through this in a couple of different scenarios. So we will cover diagnosis, we will cover the management aspect, also touch about the algorithms that are there and what practical problems we face. I have tried to incorporate in some cases, case scenarios. So awareness and treatment, we all understand that awareness may be now approximately 80%. This is US data. I will come to the Indian data also. In US, about 20, treatment is close to 70%. And but control rates, although improving, are suboptimal. Now, this is the situation for hypertension across the world. So, this rule of halves this concept was coined by Wilbur and Barrow in 1972. And this says that half of the hypertensive people in the general population, they are aware of their hypertension status. So maybe one out of two of us would be knowing that yes, we are hypertensive or we are not hypertensive. So we know our hypertension status. Half of us who are aware of this are actually taking treatment or taking measures to get well soon or control their blood pressure. And half of those who are actually taking the treatment, they are adequately controlled. So if you see out of 100 persons, only 12.5% have adequate control. So this rule of halves, the aim is to convert this into rule of three-fourths. But there was a rural study from India, southern part of India, and where they studied whether yes, we are actually progressing toward the rule of three-fourths, but the results were dismal. It were again, when you do a community study, you are again understand that the rule of halves is still persisting. So we are actually having control of hypertension in only 12.5% of the people, or maybe less or slightly more, depending upon variations, regional variations that we have. So this only emphasizes the fact that hypertension is a silent disease. So unless and until you screen for it, you will not be able to diagnose it or manage it properly. Now this is what is in the latest classification of in the Harrison. So this was the normal was less than 120 by 80 millimeter of mercury, elevated more than that, and if the blood pressure is more than 130 and or 80 millimeter of mercury, that is stage 1 hypertension, and stage 2 is more than equal to 140 by 90 millimeter of mercury. So the concept was, if patient has stage 2 blood pressure hypertension, that means more than equal to 140 millimeter mercury systolic, or more than equal to 90 millimeter of mercury diastolic, or both. So that means 140 equivalent or more, and oblique, or 90 millimeter mercury diastolic blood pressure equivalent or more. So if the patient has stage 2 hypertension, you should treat the patient. If patient has stage 1 with risk factors, then you should treat the patient. Or the ACVD risk, the atherosclerotic cardiovascular disease prediction risk in the next 10 years is more than 10%. So that is what the earlier classification was. But yes, in recent times, last year only, we have this the European Society of Cardiology classification, which has actually given a different perspective. So as postgraduates, we should be aware. Now I have one slide. It is important to understand that there is a continuum. There is no cutoff for individual persons. These are general guidelines. They are to be taken, maybe sacrosanct, yes, but you can have some arbitrary plus or minus depending upon the individual patient. So that will vary. We will discuss some of these aspects later. So the ESC, the European Society of Cardiology, defines hypertension as a persistent elevation of office systolic blood pressure more than equal to 140 millimeter mercury, or diastolic blood pressure of more than equal to 90 millimeter mercury, or both. So this is office BP. If this is has to be, this is considered to be equivalent to an ambulatory blood pressure. Now ambulatory blood pressure is when you apply that ambulatory blood pressure apparatus for 24 hours and then you take the measurement throughout the 24 hours, which is automatic readings, which it inflates and deflates periodically depending upon the time period that you have set. Maybe hourly, day, half hourly, night time. It inflates and deflates automatically and records the blood pressure. And next day, when the patient comes to you after 24-hour recording, you can transmit it to the computer and you can analyze what is the average daytime systolic blood pressure, average daytime diastolic blood pressure, average nighttime systolic blood pressure, average nighttime diastolic blood pressure, and 24-hour average systolic and diastolic blood pressure. So this is what is mentioned here. 24-hour average systolic blood pressure more than equal to 130 millimeter mercury, and oblique or diastolic blood pressure of more than equal to 90 millimeter mercury, 80 millimeter of mercury on ambulatory blood pressure is to be taken as hypertension. Now, as a general guideline, ambulatory blood pressure measurement readings are taken as 10 millimeter less than the office blood pressure measurement readings. So that actually takes off that white collar effect which we all are worried about at times. Now, this is again equivalent to home blood pressure monitoring. So, if you have home blood pressure monitoring, patient takes, so that is 5 millimeter cutoff, less than the office measurements. So this is what. So home blood pressure monitoring, you should have a BP systolic blood pressure which is more than 135 and or a diastolic blood pressure reading which is more than or equal to 85 millimeter of mercury. This is the European Society of Cardiology classification which has been enunciated last year only. Now it is important that this they have removed stage 1, stage 2, and what they have given a new class which is elevated blood pressure. They have also removed normal blood pressure. What terminology they have used is non-elevated blood pressure. So there will be some difficulty in remembering, but yes, the most important thing is that the therapeutic cutoffs remain at hypertension, office blood pressure more than equal to 140 and oblique or 90 millimeter of mercury diastolic blood pressure. Then the important thing is that they have lowered the non-elevated BP or the normal BP which was earlier as less than 120 by 70 millimeter of mercury. So 120 was earlier there. If you see this 120 was there normal BP, but now it is 120 by 70 millimeter of mercury. So this has changed. So non-elevated. So the diastolic blood pressure has been the value has been brought down from 80 to 70 millimeter mercury. And in between hypertension and non-elevated BP, now this range is elevated blood pressure. So 120 to 139 millimeter mercury is systolic blood pressure and diastolic blood pressure of 70 to 89 millimeter mercury. This is elevated blood pressure. Now, once you have an elevated blood pressure or hypertensive range BP first time, then you should ask for a confirmation in this patient by either home BP measurement or ambulatory blood pressure measurements. So this is what the European Society of Cardiology has recommended. So single office BP in the elevated BP recording range or the hypertensive range, you should a subsequent confirmation by home BP recording or an ambulatory blood pressure measurement. And if the blood pressure is between 160 to 179 and 90 to 109 systolic and diastolic respectively, you need to get a confirmation within a month, which they say as a prompt confirmation. And if the blood pressure is very high, that means more than equal to 180 systolic blood pressure and 110 diastolic blood pressure, then you have to rule out hypertensive emergency. So the term hypertensive urgency has gone out in this new classification. So these are some of the changes that we actually should be aware, because for postgraduates who are going for the examination, this is important. So the diastolic reading has gone down to 70 millimeter of mercury. The stages of hypertension have been removed. The hypertensive urgency term has gone, and if you have a high blood pressure, office BP recording for the first time in a patient who was not diagnosed to be hypertensive, you need to reconfirm that subsequently by either home BP monitoring or an ambulatory blood pressure measurement. Now, this was what I was saying. Despite these cutoff values, mind you, this is a continuous risk model. So, as systolic blood pressure measurement increases and as diastolic blood pressure measurement increases, so the risk for cardiovascular disease and complications of BP increase. That is why they have actually changed from the pre-hypertension definition to high normal definition to now elevated blood pressure. So they say non-elevated blood pressure and elevated blood pressure. So elevated blood pressure has a higher risk compared to non-elevated blood pressure, and hypertensive population more than equal to 140 and or 90 millimeter of mercury systolic or diastolic blood pressures respectively have a much greater risk, even more than the elevated blood pressure measurements. So I think this is clear to most of you because you have a background knowledge. I have just told you the changes that are there. Now, this we all understand. I am not going to the methodology of measurement because it will take a lot of time. We will not be able to complete it in an hour. Use validated devices. Now, mind you, we don't have too many validating agencies, but yes, ideally you should have validated devices. And the concept is coming, and we will soon have validation of most of the devices at most of the centers. Confirm diagnosis with multiple readings. So that is how home BP makes a dent, because you can have measurements multiple times at home, and ambulatory blood pressure also. As I said, you can have 24-hour recordings, 48-hour recordings, and it will automatically record all the recordings during daytime or during night time, even if you are sleeping. And yes, this is important. Assess with both office and out of office methods. So that is what the guidelines say. You have a high office BP, you confirm with a or home BP or an ambulatory blood pressure. So this is a very radical change in hypertension management and the classification and diagnosis. White coat hypertension I just talked about. So when you measure in the office, the blood pressures are high, but ambulatory blood pressures are non-elevated or normal. So that is white coat hypertension. And masked hypertension is the opposite of this. That means in the office, the blood pressure is normal. In the clinic, the blood pressure is normal. But when you do an ambulatory blood pressure monitoring or a home BP monitoring, the blood pressure is found to be high. So obviously the masked hypertension is very important to detect because that is a risk factor. Because in the office the BP may be normal, but otherwise the patient is having a high blood pressure throughout. So BP monitoring, now the home and ambulatory are more predictive. That is why the emphasis has been given. So they predict cardiovascular events much more, and they also are consonance with the 24-hour blood pressure which the individual has. The another important thing is when you do an ambulatory blood pressure monitoring, you check for the nighttime dip. Those who are dippers, so the nighttime average blood pressure, systolic as well as diastolic, should be 10% to 15% less than the daytime blood pressure. And this nighttime dipping is considered to be a normal rhythm and a protective rhythm, protective for end organ damage. So we'll talk of end organ damage, but it will prevent end organ damage or target organ damage for hypertension. This I think we have discussed ambulatory and home monitoring. So ambulatory blood pressure is preferred for detecting white coat mass hypertension, we just discussed. And home monitoring, in addition of that to diagnosis, it also improves adherence in reinforcement and engagement of the patient. Sorry. So we will come to just a minute. Yes, screening for secondary hypertension. So now at times you will feel that why there how many patients of your hypertensive group are actually having secondary hypertension. So it is important that you should suspect it. If a patient is abnormally obese, if the patient has sleep apnea, And if the patient is having daytime sleepiness, those could be indicators. Then in patients who have extremes of age, maybe more than 60, 65 years of age and less than 40 years of age. So these are the patients where you should actually think of secondary hypertension. So this is important because secondary hypertension is important to identify, because essential hypertension you need to control with lifestyle and pharmacotherapy. Secondary hypertension at times may be treatable also. If you have an adrenal cause, if you have obstructive sleep apnea, it may be treatable once you treat the cause. Although this contributes to only 5% of the total hypertensive population, but it is important to find out this group. So severe hypertension, very high BPs, episodic hypertension, resistant hypertension, all these are, if you have heart failure which is coming in with every episode, if you have other symptoms with hypertension, these are all indicators that the patient may be having secondary hypertension. Skin rash associated with hypertension, these could be all causes. Now, when you talk of hypertension, you always check for other things. Even the first time hypertensive that you have detected, or high BP or elevated blood pressure that you have detected, you should check for target organ damage. So, what are the target organs? Brain and eyes. So, fundus examination is very important. You can get retinal hemorrhages, you can get arterial narrowing, and in brain, manifestations could be any. It could be microvascular infarcts, it could be a florid stroke, it could be a hemorrhage, or at times it can contribute to atherosclerosis and its diseases. In the heart, obviously, coronary artery disease, left ventricular hypertrophy, aortic dissection with very severe hypertension, and vasculature, you can have peripheral arterial disease. Kidneys face the brunt at times, and you can have chronic kidney failure and at times acute kidney injury also with very high surges of blood pressure. Now, this is the complication. So, you have the brain, you have the heart, and you have the renal system and the peripheral arteries. So, they are the target organ damage. But whenever you have a case of hypertension, also rule out comorbidities. So, diabetes is important comorbidity, dyslipidemia is important, obesity is important. So these are important comorbidities. And the third thing is always suspect, is the patient having secondary hypertension? So I gave you clues to that. You can have anasarca, you can have rash, you can have resistant hypertension, you can have severe hypertension, you can have episodic hypertension in your patient. All these things, difficult to control hypertension, all these things will actually point an indicator that your patient may be having actually secondary hypertension and not essential hypertension, and you will need to have a different data set or investigation modality. This we just discussed. Heart effects could be left ventricular hypertrophy, congestive heart failure, arrhythmias, CAD risk is increased, and LVH, left ventricular hypertrophy, is actually reversible. If you control blood pressure and you have drugs like ACE inhibitors, you have mineral corticoid receptor antagonists, all these can actually revert the left ventricular hypertrophy to a fair degree. Brain effects we discussed. You can have multi-infarct dementia, you can have encephalopathy and malignant hypertension, you can have stroke, ischemic or hemorrhagic. Kidney damage again. Proteinuria is a very early marker. Always check for proteinuria and especially microalbuminuria. So if you have that, that means the kidneys are facing the damage. Give drugs which can actually be renoprotective like ACE inhibitors, ARBs, MRAs. Glomerular sclerosis and ischemia, I discussed. CKD or AKI both can be seen. CKD more common, AKI with only rapid surges in BP. Peripheral arterial disease is, yes, manifests atherosclerosis, hypertension contributed to atherosclerosis in the limbs, which manifests as peripheral arterial disease. And what we do is an ankle brachial index. We check for the ankle brachial index, and if it is less than 0.9, that actually suggests that the patient is having peripheral arterial disease. Now, this concept is also very important. Most of you would be aware, but it is important to understand that, sorry, central blood pressure readings are more important than brachial blood pressure readings, and they are not equal. So, there are tools now to assess central blood pressure readings. So there will be devices which are there. Not all devices exist right now. They are costly devices. But yes, you can compute central aortic pressure or central blood pressure, and that actually reflects more truly the vasculature and the arterial stiffness, and correlates more well or much better than the with the target organ damage than the brachial blood pressure. So let us see, because right now these tools are not standardized, so these are only research tools, but maybe in future we will have tools which are readily accessible, which are standardized and validated tools, which can actually detect central aortic blood pressure measurements, and we will be controlling central aortic blood pressure vis-a-vis the brachial blood pressure, because central aortic blood pressures are much better and indicate the, as I said, they correlate very well with the target organs. And as I said, predictor of cardiovascular disease. Oh, sorry, just a second. Yes. Now this is very, very important. For each 5 millimeter mercury reduction in systolic BP, this is a recent meta-analysis, the risk of cardiovascular events decreased by 10%. So imagine if you have 5 millimeter mercury reduction, the risk of cardiovascular events is decreased. Now, mind you, when we are talking of classification, right now the present classification, the European Society of Cardiology classification, does not include the CV events, the ASCVD calculation. But earlier it was mandatory. Right now also this is, you should always assess for atherosclerotic cardiovascular disease using the index and the calculator, online calculator you all have, and this will indicate, so we calculate the ASCVD risk over the next 10 years, and if it is more than 10%, then it indicates a very high risk. If it is between 5 to 10%, then it is moderate risk. So if you are achieving 5 millimeter mercury reduction in systolic BP, you are doing wonders for this patient, and you can reduce the risk of cardiovascular events. That means stroke, MI, heart failure by 10%, which is very important, and that is the benefit which we need to make aware to the patient for ensuring adherence and compliance. So this is important. Even a modest BP reduction can lead to significant gains in preventing incident or recurrent cardiovascular disease. Now I will have some or quite a number of cases. So we have time and I will discuss them. So there is a male, 45-year-old male who checks his BP routinely. It is 130 by 80 millimeter mercury. Now, so with the current guidelines, this blood pressure is not elevated. But definitely this blood pressure, if you measure at home, this is elevated blood pressure. So we had this, if you remember correctly, I will just come back to this. So this is 130 by 80 millimeter of mercury. This was in the earlier classification stage 1 hypertension. In this classification, so home BP 130 by 80. So this is, you can see non-elevated, this is elevated BP. So 130 by 80 millimeter mercury measured at home. So this patient actually measured at home, and this came to be an elevated blood pressure for this patient. Now he checked in the evening. Again it is 134 by 85 millimeter of mercury. So this is the advantage of home BP. You can check. It will give you a positive reinforcement also to the patient. So this patient, if he does not have other risk factors for atherosclerotic disease, this patient is now elevated blood pressure. So you need to emphasize lifestyle modification for this patient. No need right now for pharmacotherapy. So this is another patient, routine BP, he checked at home, it was 144/88. Now this is a high blood pressure by all means. So now again, I have already discussed the, once you have an elevated systolic or diastolic blood pressure, the cutoff was 140 by 90 millimeter of mercury for office BP. And if you have a blood pressure somewhere less than that, but if you have comorbidities like diabetes, chronic kidney disease, proteinuria, and coronary artery disease, you want a lower blood pressure. So you need to have 130 to 139 and 80 to 89 millimeter of mercury when the target, this is the target. So for hypertensive population, it could be less than 140/90, but for the hypertensive population with comorbidities, you have to have a lower target. So this is important. All these conditions, you have to have a lower target with any of these comorbidities, CKD, diabetes, proteinuria more than 1 gram per day, and CAD. You have to have lower targets. Don't go for the target of 140/90 millimeter of mercury. So when you have to manage, the most important thing comes diet, and most important thing is salt restriction. So you want that the patient should have salt less. So when you advise for salt restriction, how do you advise that? The recommendation in textbooks is less than 6 gram per day, which is equivalent to roughly sodium of less than 2.4 gram per day. But nobody calculates that. So you advise the patient and the family to use the minimum salt that is required for the vegetables or the pulses to be made. Because if you tell the housemaker that don't put any salt, then the housemaker will say, how will my vegetables cook? They will remain hard. Or how will my pulses cook? They will remain hard. So they have to add a little amount of salt. So ask them to advise them to add minimum salt. And when it is served on the table, ask patient that there should not be any salt sprinkled over the diet or lunch or dinner or any meal that the patient is taking. So at times you will advise for a low salt in when the diet is the food is made, lunch or dinner is made, but then patient will have some salads and on the salads patient will sprinkle. So that is what we actually advise for a no added salt diet. So no salt is to be added in any form. And some people will say we will develop hyponatremia, we will develop giddiness, we will develop weakness. So you have to tell them, explain to them that all things which grow, even pulses or vegetables, they grow in this earth. And earth has a fair degree of salt. So all these they have inherent salt, just like our medications. They are either sodium salts or potassium salts. So your medications also have salts, sodium. So similarly, you have sodium stearate, you have so many salts. When you will check your injections, you will find there is an amount of sodium in that also. Although it is minuscule, but still. Similarly, all food items will have some sodium because that is an inherent composition. So that is why you say no added salt diet, because then also patient will have some sodium and it will be less than 2.4 gram of sodium per day. Some people will ask, can I use rock salt, or can I use sendha namak, or can I use black salt? All salts have sodium and they have to be restricted. Some salts, in fact, will have more sodium than table salt, like rock salt at times or sendha namak at times. So they all have sodium with varying contents, so they cannot be advised. There is an option of a low sodium salt. So you have low Na, sodium natrium, so Lona salt, or there are some other preparations also. Now you should remember that low sodium salt is low in sodium, but it is not no added salt diet. It is still is salt. So the only difference in low sodium salt is that salt has sodium chloride mixed with potassium chloride. So if there were 100 grams of sodium chloride in low sodium salt, there would be maybe one third, two third ratio. Two third may be potassium chloride, one third may be sodium chloride. So salt would still be there. So you should, if at all patient is not able to have a no added salt diet, you can say you can sprinkle a little of low sodium salt diet. Ideally not. But yes, if the patient is not able to have, then at times you may need to resort to that tactic so that the patient at least has less salt than table salt. So it is not that low sodium salt you can use in excess. It will again contribute to sodium intake. Now, the second step apart from sodium restriction is DASH diet or Mediterranean diets. They are not applicable for India. But remember, the hardcore or the main core of these diets is that these diets are rich in fiber and a fair degree of nuts. So you have fruits, nuts, and vegetables in diet. and that is what actually comprises DASH diet. So in the Indian setup, you should always don't advise Mediterranean diets because that is rich in fish. Then you will have fruits, nuts, and they are costly items. If you are treating patients who are poor or from the lower socioeconomic strata, they will not be able to afford that. So you advise them to have one fruit portion, have some raw vegetables, and if they can afford nuts, that is good. The second point in management essentials, now these are lifestyle modifications, these are dietary modifications, these are very, very important, and at times these will bring down the blood pressure of the patient by 5 to 10 millimeter of mercury. So these have to be advised to any patient who has an elevated blood pressure before he or she develops hypertension. So advise the patient to quit smoking, tobacco in any form, alcohol also. Meditation, yoga, regular exercise are very helpful, and if the patient can include them in their lifestyle, it is a bonus. And they should actually include or imbibe these measures in their day to day schedule. And another thing is de stress themselves. Now, this is important, it is very difficult, but yes, people have to learn to de stress. Now, those patients who are obese or overweight, they have to be advised for weight reduction. Now, weight reduction regimes are totally different, and you will have to spend extra effort to manage their diet. Tell them not to snack or evening snacking, late night snacking, or daytime snacking. Everything has to be curtailed, and even diet in during the lunch or dinner also has to be restricted. And if the patient is not able to achieve weight reduction, at least advise for weight maintenance. So the first step is weight maintenance. Patient should not continue gaining weight. Once the patient is able to maintain weight, then after a couple of months or 3 months, 4 months, you should advise the patient to intensify his life or her lifestyle and reduce the dietary calorie intake and give a another push for weight reduction. So now this gentleman, so I have talked about the basics of blood pressure, especially in those patients who had elevated blood pressure. So you can just do with the advice which is written here and wait for pharmacotherapy. Now this patient who has 45-year-old male, but this patient has a blood pressure of 150 by 100 millimeter mercury. So outright this is hypertension and this patient requires pharmacotherapy. So the concept now, when you talk of pharmacotherapy, I think I have next slide. I will talk to you then. Yes. So this was the earlier concept that you have A, B, C, D group of drugs, where A stands for ACE inhibitors and ARBs, B for beta blockers, C for calcium channel blockers, and D for diuretics. So you can use any of these drugs ideally, and obviously alpha blockers also. So these are first line drugs which can be used, and any drug can be used. But the recent concept, the European Society of Cardiology concept, the first concept is that you use two drugs in low dosage because they have synergistic effect and they are much better. So you should be using two drugs in low dosage. Second step is to add a third drug. If you do not achieve the goal, you add a third drug again at a lower dosage. And the step three is that you go for all the three drugs in maximal doses. So this is important because this is the concept given in ESC or the European Society of Cardiology. Prior to that, their concept was this ABCD, where you should combine, you can use any of these as monotherapy. And if you have to combine, you combine A with B and C with D. Usually not A with D or B with C, because we all understand beta blockers, calcium channel blockers, they have the potential to cause heart blocks because both are actually acting upon the cardiac myocytes, and ACE inhibitors and diuretics also, although there are a number of combinations. But yes, it is important to understand now the concept is changing and you can use any combination. But this was the trend earlier that A plus B should be used and C plus D should be used. And A plus B was preferable in younger patients and non-blacks, while C plus D would be preferable in older patients and blacks. And once you are not able to achieve, then you go for combinations. But the European Society of Cardiology guidelines, the recent guidelines which have come, they state that you can use any of the five groups as first line, and preferably not beta blockers, although beta blockers can be used as a compelling indication, but otherwise you can use any of the five drugs, the five classes of drugs, and but use them in a combination at a low dose. So first line therapy is low dose, two drug combination, and if the goal is not achieved, you go for a third drug again in a dose combination, low dose. And once again, if the blood pressure is not controlled, you go for step 3. Mind you, all step 3 is going for maximal dosages of all the three drugs. But mind you, all these things would not be possible without hypertension management essentials 1, which I have said, and management essentials 2. It cannot be that the patient is taking tobacco and alcohol and smoking regularly and you are giving antihypertensive therapy or taking sodium in large amounts. So those things are ancillary, they are essential, and on the top of it, you can give pharmacotherapy as discussed. Now, this is another patient, case 4, 55-year-old male, recent MI, blood pressure is on the higher side. Now, this is a compelling indication. This also is still there, this concept, and you should know. Similarly, this patient, so compelling indication is MI. So, this patient of myocardial infarction which has hypertension, you should use cardioselective beta blockers like metoprolol or carvedilol, which will bring down blood pressure also and will be cardio beneficial or cardioprotective also. We will have actually survival as well as quality of life benefit in a recent MI patient. Similarly, if you have a patient of 55-year-old male who has persistent AF, so you should ideally also rule out secondary hypertension in this case because this patient may be having hyperthyroidism as cause of atrial fibrillation. But otherwise, again, if you have atrial fibrillation, you may want to start this patient on a beta blocker drug or at times a calcium channel blocker drug so that you can control hypertension as well as AF. Mind you, these days the dihydropyridine drugs of calcium channel blockers which are available, they will not actually control AF or bring down, they will only bring down blood pressure. But yes, beta blockers again in this case, if there are no contraindications, you should be able to use, which can actually control AF if you are giving. But yeah, I am not talking about the other management options for AF because you will need to anticoagulate this patient also, see for the cause of atrial fibrillation. So now these are the compelling indications which I am talking about. So if you have a patient of CAD or acute coronary syndrome, you have to use beta blockers. You can use ACE inhibitors and ARBs because they prevent LV remodeling, which is important from the point of view of acute coronary syndrome or coronary artery disease. Similarly, if you have arrhythmias or especially tachyarrhythmias, you have to use beta blockers or calcium channel blockers to control hypertension. Hypertension with fluid overload states, use diuretics and ACE inhibitors. Anxiety states with hypertension, beta blockers, compelling indication. Diabetic patients, if they have hypertension, use ACE inhibitors, ARBs. The benefit with ACE inhibitors and ARBs for renal protection is not available with most other drugs. If at all they are there, some calcium channel blockers also have some benefit, indapamide also have, but they are not very effective, or there are at times reports which suggest they may not be benefiting more than lowering the blood pressure. But ACE inhibitors and ARBs, they lower the blood pressure also, they also control the or they prevent kidney disease and they reduce albuminuria over and above the reduction in blood pressure. Left ventricular hypertrophy, again, ACE inhibitors, ARBs, some calcium channel blockers. Elderly patients, calcium channel blockers and diuretics. We just saw CD group, calcium channel blockers and diuretics. Prostatism, alpha blockers, because they will be relaxing the smooth muscle of the prostate also and benefiting the hesitancy and urinary symptoms. Now, this is another case, 40-year-old male, chronic smoker, high blood pressure, again, hypertension, 144/98 millimeter mercury. If you have this BP, you just corroborate that at another home BP or ambulatory blood pressure as per the ESC guidelines. But the patient has audible wheeze, probably because of chronic smoker state or maybe having associated COPD. So, in this patient, you don't use beta blockers because beta blockers can actually cause wheezing or worsen wheezing or COPD or bronchial asthma control. So whenever you prescribe antihypertensives, always remember contraindications. Now this is very important because if you do not remember the contraindications, so we talked of drugs, we talked of compelling indications, now we are talking of important contraindications. So COD, AD and asthma and diabetes, if they are uncontrolled, then do not use beta blockers. In diabetics, we avoid beta blockers because they can actually suppress the sympathetic overdrive when the patient has, or the sympathetic symptoms when the patient has hypoglycemia. So the hypoglycemic symptom, the sympathetic activation may not be manifesting when the patient is on beta blockers. So the patient can go into hypoglycemia and worsening hypoglycemia if the patient is on beta blockers. Similarly, COAD and asthma can actually worsen with beta blockers. So this is important contraindications. If the disease is uncontrolled, then you have to be very careful. Volume contraction states, don't use ACE inhibitors or ARBs or diuretics. Although ACE inhibitors and ARBs are beneficial, they are renoprotective. But in a volume depleted patient, they can be the cause of AKI. So they can worsen acute, they can cause volume depletion states, they cause acute kidney injury. So this is very, very important. Don't use. You have to ensure that your patient is volume replete before you put a patient on ACE inhibitors or ARBs or on diuretics. Orthostatic hypotension, calcium channel blockers as well as alpha blockers. They are known to worsen orthostatic hypotension. Like alpha blockers are notoriously known to cause first dose hypotension also. That is why you advise them at bedtime when the patient is just about to lie down and unlikely to get up for the next couple of hours. Hyponatremia, gout, diabetic patients, don't give thiazide diuretics. Again, important. Hyperkalemia, ACE inhibitors, ARBs, and MRAs, mineralocorticoid receptor antagonists, spironolactone, don't use because it is potassium sparing. ACE inhibitors, ARBs, also they have a tendency to cause hyperkalemia. You can contribute to worsening hyperkalemia and life-threatening arrhythmias. So these are important contraindications which we should all be aware because they are common in our hypertensive patients or maybe coexisting. So we need to be very, very careful. Now this is another case, 755-year-old male. I think this is the last case, 170 by 110 millimeter of mercury blood pressure. And he has anasarca with early morning facial puffiness. So the first thing that comes to your mind is with early morning facial puffiness and anasarca that this patient probably has renal disease. So this is probably a case of secondary hypertension. So elderly, middle-aged male, hypertension which is high, severe, and anasarca with early morning facial puffiness pointing to kidney disease. So this is probably a case of CGN or CKD, and this patient will have secondary hypertension. And many of these patients, once you make them, they reduce their volume overload, they will actually, blood pressure will also come down. So you need to take care of these patients in a different way. You will need to give multiple drugs, high dosages, and diuretics also, depending upon the kidney functions. So yes, I already told you the pointers, but yes, I have enlisted also. So extremes of age, secondary hypertension, less than 30 years, more than 55 years. If you have accelerated or malignant hypertension, rule out secondary hypertension. Difficult to control BP, recurrent BP surges or episodic hypertension, resistant hypertension. If you have a very obese patient or obstructive sleep apnea, obesity per se is not secondary hypertension, but yes, obesity may be indicator of Cushing syndrome, or severe obesity may be associated with obstructive sleep apnea syndrome. So you have to be very careful. That can be contributing to secondary hypertension. Again, presence of atypical features like abrupt onset of hypertension, electrolyte abnormalities, and atypical fat distribution. These are some of the pointers towards secondary hypertension, which we should all be able to identify because we should not miss a single patient of secondary hypertension because this is treatable, mind you. Well, I think this brings to the end of my talk. Thank you so much. And if there are any questions, I will be glad to answer. I will just see there are, I think, some of the questions in the chat box. Just let me go through to the chat box. So there is a question post delivery if the BP is within normal range with labetalol twice daily. What is the best hypertensive in postnatal mother, sir? See, you have to in a postnatal mother you have to be cautious that the drug should not be secreted in the breast milk. But most of the antihypertensives are actually excreted in the breast milk. But importantly, they are in very minuscule amounts, so you don't need to worry about that, and you can start the patient on any drug depending upon what is the scenario. If there is no compelling indication, you may not be given. Now, this is again important. If the patient is on labetalol, probably the patient was eclampsia or preeclampsia types, then the blood pressure would be normal and you will need to reduce the dose and you may not need to continue any antihypertensive medication in such a patient. But if the patient is essential hypertension, has developed at high blood pressures during the pregnancy time, then obviously you can bring the patient back to the same drug. But labetalol we usually use only with severe hypertension in pregnancy. Otherwise, our drugs like calcium channel blockers are good. During pregnancy, you don't have to give ACE inhibitors. That is very, very important. Don't give because it can result in renal agenesis in the in baby. What is the cutoff EGFR to stop ACE inhibitor ARB? So again, this is very important. You can ACE inhibitors and ARBs are renoprotective. There is no cutoff EGFR if you go by the academics. What you have to be careful about, even in patients who have proteinuria and who may be normotensive, you can still give ACE inhibitors ARBs. Even at high serum creatinine, you can give. The only problem with ACE inhibitors ARBs is that they cause hyperkalemia. So in a patient of CKD who has stage 3A or 3B or 4 or 5 or is CKD stage 5D on dialysis, these patients have a greater propensity to develop hyperkalemia. So if you are using ACE inhibitors ARBs and not monitoring them frequently, then the patient you may lose the patient because the patient will develop very high serum potassium levels which will be worsened by ACE inhibitor intake, and then you will land in a soup. So it is not advisable to continue ACE inhibitors or ARBs beyond CKD stage 3A. So with 3A, yes, you may continue with fair degree of monitoring. Stage 3B, 4, 5, not advisable. Why BP always measured in millimeter mercury? Why not centimeter of water? Now, this is important from the point of view that mercury does not evaporate at ordinary temperatures. And the standard measurement for the pressure is in mercury only. So the original standard which is there is in mercury. Mercury is much more stable than water. So this has been the standard for a very long time, and that is why now with phasing out of millimeter mercury manometers, we are facing a problem in validation and in measurements. But yes, I think validation is on way, and with AI tools now available, I think that should be very soon. You will have many agencies which will be validating these instruments. So it is invariably in millimeter of mercury and not in centimeter of water because the original standard of pressure measurement is in millimeter of mercury. Not for blood pressure measurement, but pressure measurement. The physics that you have learned, you will remember that it is all in millimeter of mercury. How to interpret home-based readings using the ESC guidelines, sir? So home-based BP readings, you should remember crudely 5 millimeter less than office BP and ambulatory blood pressure measurement readings 10 millimeter less than office BP. And the cutoffs are 140 by 90 in the ESC guidelines, office BP. So after office BP measurement, after a baby, if you ask the patient to come back after a week or 2 weeks, and you can ask the patient to bring a record of the blood pressure measurements. So if the blood pressure readings are more than 130/85 even at home, then you should think that yes, this patient has hypertension. Hypertension medication should be taken AM or PM. See, ideally, what you want to achieve is you need to achieve 24-hour control of blood pressure. That is your number one aim. Number one aim, once you achieve that, yes, 24-hour control of blood pressure. The second aim is you should have your dipping pattern restored. Now, there have been a number of studies, we have also done a number of studies to assess whether the AM medication or PM medication makes a difference. Now, remember that was with monotherapy, with some combination therapy also, but very few studies and very small number of studies said that yes, PM medication would actually restore the diurnal rhythm. If you give in the evening, the nighttime blood pressure reduction would be much more than daytime blood pressure reduction, and it would actually restore diurnal rhythm and also benefit the patient. But there has been a recent meta-analysis last year, I remember, which says that right now AM or PM medication giving does not make any difference. So the cardiovascular outcomes were uniform whether you give the medication AM or PM. And with the ESC guidelines now, if you are using a combination therapy, low dose, so AM or PM will not make much of a difference. And I think you can give what the patient remembers to take. So adherence is very important when you can ensure compliance. So ask him to fit it. If he remembers taking it daily in the morning, no, never mind, let him take in the morning. If you remember, it is easier for him once he comes back in the from the office and at tea time he can take, never mind, or at bedtime. So the patient has to incorporate the medication in his schedule. Taking the medicines, bringing down blood pressure, 24-hour control is much more important than the timing right now. That is the present day evidence. If a patient has been on amlodipine plus etalol combination for hypertension and has been controlled, is it recommended to switch to ACE inhibitors or ARBs or continue her on the same? Now, if the patient has a controlled blood pressure, don't change the medication. Most of the studies that you will go come across or you will read, you will find that the most important benefit with antihypertensive benefit is because of reduction in blood pressure. Whatever way you achieve, be it with pharmacotherapy, be it with meditation, be it with quitting of tobacco, be it with quitting of alcohol, be it with salt restriction. If you achieve the reduction with any drug, it is much better, or even without drug, that is much better than actually changing the medication because of academic reasons. As I have just showed you, the guidelines change, the drug therapy changes. So with every change, you cannot keep on these guidelines. AHA will have guidelines every 3 years, ACC will have every 5 years, ESC will have every 3 years, and not all of them will come same time. So in 5 years time, you will have three guidelines, and now you are going to have Indian guidelines also next year. So in 5 years time, you will have four guidelines, and you cannot just keep on shuffling your patient because of that. So if your blood pressure of the patient is achieved, then let it be and let the patient be happy and you also remain happy. That is my suggestion. Which is best IV antihypertensive in intraoperative period? Now, in intraoperative period, it will all depend. See, intraoperative period, you usually don't give IV antihypertensives. It is important to understand that most of your anesthetic agents are hypotensive. Number one. Number two, during the surgery, there is some loss of blood also. So, hypovolemia, which also results in some hypotension or reduction in blood. Now, the causes of intraoperative hypertension are different. At times, number one, it is because of the anxiety that the patient was having just before the surgery. So, that may be continued, but as the surgery progresses, it will go down. Number two, the cause of intraoperative period hypertension could be the intubation process which was there. So the causes of intraoperative hypertension are different. At times the patient may be having autonomic neuropathy. So those causes may be different because of which the patient has intraoperative hypertension, and ideally medicine people should not be intervening in that. It is best left to the anesthetic to manage intraoperative hypertension, and if at all you have to use, you use very short acting antihypertensive. You cannot give an antihypertensive which acts for 4 hours, the surgery goes on for 2 hours, and then after 1 hour, the patient becomes hypotensive, and then you are wondering how do you reverse the effect of your antihypertensive. So you can use nitroglycerin, you can use sodium nitroprusside, all those agents within minutes as soon as you stop those IV preparations. So those drugs, IV nitroprusside, IV uh, nitroglycerin, those drugs actually act within minutes and act for a few minutes. As soon as you omit the IV infusion, those drugs would cease to have their effect. So, if the patient has bled or if the patient develops hypotension, then obviously you will not be in a soup that you will now be asked to reverse the effect of your antihypertensive that you have given. So the next question is IV metoprolol is safe during hypertensive heart disease in acute state. So if the blood pressure surge is acute, yes, definitely IV metoprolol can be given. And you can give IV metoprolol in case of hypertensive emergency and continue the patient on oral metoprolol later on. So that is safe. Even IV enalaprilat is available. That also you can use. So whatever preparations, even IV calcium channel blockers, you can use all those drugs in hypertensive emergency. Mind you, in hypertensive emergency, not otherwise. Well, I think there are no more questions, and we have completed 1 hour also. 2 minutes remain because we started 2 minutes late. But I think thank you. You people have asked quite a practical questions and queries which are there, and I hope that you have got your answers to the same. Well, thank you. With the permission, again thank Dr. Kamlesh Tiwari, Dean ICP, for giving us the opportunity to conduct these sessions, and I am sure it benefits all those who are attending. Thank you so much. Thank you. Have a great weekend.
Thank you, sir. It was wonderful talk by you, and every aspect I think everyone has understood because the cases you have discussed were actually very nice and self-explanatory, I may say, because you have actually explained it very nicely, and the treatment options also, whatever you have discussed and how we should approach, that was very nice. So I think that's why there are no questions because they have, I think, understood the thing. There are few
Well, thank you,
questions, sir.
Dr. Shubhlakshmi.
Is IV metoprolol this one?
This I took. This I have
Yes,
took.
yes, sir. Yes, sir. You have taken this question. Yes, sir. So now, thank you very much, sir, and I thank all the attendees also for this uh, lecture, attending the lecture. And next time we will be again meeting with a new clinical sign or symptom that will be helpful in our daily clinical practice. So thank you,
Yes.
sir.
Thank you. Thank you. All the best.